So Michael, one of the remarkable pieces of information that's come out in the last 3 to 6 months is while we've spent the last decade studying many molecules in the advanced disease setting, we continue to recognize that there's this group of patients called high-risk resected. Many of us see those patients where they've undergone their surgical procedure, they don't have measurable metastatic disease on imaging, but we know that based upon work that I did at UCLA with Ari Beldigren and others, that there's a real risk of this disease coming back and threatening their life. And then we had the first introduction of the adjuvant world in what's called the ASSURE trial with Naomi Haas telling us that when one looked at placebo versus sorafenib versus sunitinib, there really wasn't any benefit to the use of adjuvant therapy in that population of patients. And most recently, Alan Ravaud has talked about in JCO an article that looked at sunitinib in the same, not exactly the same, but in a group of patients with high-risk resected disease. Are we ready for prime time in the adjuvant setting to use a TKI?
It's a good question. So this data is quite confusing. I think it's potentially good news for our patients because, like you said, we know that there are certain groups that are very high risk, and we haven't really been able to do anything based on any data to reduce their risk. In terms of looking at the several trials and thinking about why there were differences, I think it's really important to kind of go a little bit into the weeds. So, thinking about the STRAC study, which was the positive trial of adjuvant sunitinib versus placebo, that was a trial that looked at about 600 patients with high-risk disease, and it's important how that is defined. So that was defined as at least a T3 tumor and or node-positive disease. Those patients were treated with sunitinib, again at the standard 50 milligrams daily dose on the 4-2 schedule. Patients were started, importantly, at that dose and not reduced. That study did show a 24% reduction in the risk of disease progression as defined by radiographic evidence of disease or death. Side effects, were comparable with what is the known side effect profile of sunitinib. So I think to really understand why this trial might have been positive versus ASSURE, say, you really have to think about some of those differences. And they are that ASSURE enrolled lower risk patients, so they did allow some patients who were not T3 or node positive. They did allow patients who had non-clear cell RCC. They also had an amendment whereby they decreased the starting dose of both drugs. This was an adjuvant trial of sorafenib, sunitinib, or placebo. So they were not starting and maintaining that dose intensity. So, when you take those factors into account, it could explain in part why STRAC was positive while ASSURE was negative. Another thing, though, that has raised controversy is in STRAC, the benefit was seen in terms of independent radiographic review in terms of the primary endpoint. It was really not seen, barely though, it was really not seen by investigator-assessed review. So that's also a little bit confusing. So we've also heard by press release that the PROTECT study, which was a study of pazopanib, or placebo, again in high-risk patients defined still a little bit differently, was also negative. That study also reduced the starting dose after a time period. So in summary, I would argue that sunitinib is ready for prime time. Again, as we were talking about some of the other drugs, sunitinib is not a drug that's just come onto the scene. This is a drug we've been using for 10 plus years. We know the side effect profile, we know how to use it. I think it's very critical, though, that we identify those high-risk patients as they were identified in the trial, those T3 and or N-positive patients, and that we start at the starting dose of 50 milligrams daily on that 4-2 schedule. So in other words, if you're extrapolating it to a little bit lower risk, you're including non-clear cell, you're reducing the dose, you're probably not going to get that benefit. I think also you have to think about the patient's goals of care. There are some patients who it may not be appropriate to put through 1 year of sunitinib based on their goals of care. I think it has to be a motivated patient that understands the risks, that's going to work with you to kind of in tandem or in the group manage the side effect profile to maintain that dose intensity.
Tony, you want to weigh in?
Yeah, I'm not, I have to be provocative here for Michael. I mean, what Michael said, his interpretation is overall correct. But in the adjuvant setting, in genitourinary malignancies in general, because all of us here, you know, most of us are genitourinary malignancies, I would like to see survival benefit. There was absolutely no survival benefit after 5.4 years median follow-up on STRAC. The other thing is, or at least the trend toward that, because now what we started the conversation with, Bob, is active surveillance. So all those patients that, you know, recurred, because there was a median disease-free survival, you know, disease-free survival on STRAC was, you know, prolonged by 1 year, so delayed by 1 year. So the question is, were these recurrences done on modern day scans in the lung, few spots like this where, you know, folks could have waited a bit to start the treatment, or were these recurrences in terms of brain metastasis, liver metastases, bone metastases that need something immediate? There was absolutely no overall survival benefit. Going back to Dr. Haas' study, which was really almost 2,000 patient study, and it's true, it did enroll non-clear cell, it did enroll lower risk patient up to T1B, but this study also had a significant amount of patients that were really high risk, N positive, T4, T3, grade 3, grade 4, Furman grade 3, 4. And when you look at the subgroup analysis, there is no signal in terms of disease-free survival or overall survival. Not even a hazard ratio, you know, lower than 0.9, for example. And now we know in the public domain that the pazopanib study, you know, didn't meet its primary endpoint. So I am not sure that we accepted the adjuvant paradigm now. And having said so, there's a lot of ongoing studies. We're still considering disease-free survival, perhaps to have a you know, powering issue in terms of sample size. But I think it's important in those patients that are cured with after nephrectomy to see if we can cure them more with an adjuvant therapy rather than delaying a treatment that may not kill them.